Good morning. My name is Sophie Gamer, and this is a presentation on the United States Preventative Services Task Force recommendations for screening for depression in adults. I will be introducing the area of interest. Alyssa Capili will discuss the clinical practice guideline. Ellen Colwell will discuss the method used in this analysis. Emilia Vasilchuk will discuss clinical recommendations. And finally, Yoonsung Choi will discuss the study's conclusions. So I would like to begin by defining depression and discussing its prevalence in the United States. The U.S. Preventative Services Guidelines cover two types of depression, major depression and postpartum depression. Both of these forms of depression are treatable conditions that affect millions of Americans yearly. First, I will discuss major depression. There are a variety of symptoms associated with the condition, most commonly including depressed mood, changes in appetite, and changes in sleeping patterns that could result in insomnia or excessive sleeping. Other symptoms may be weight loss or weight gain, fatigue, difficulty focusing or processing information, feeling worthless or guilty, having a lack of interest in hobbies and social interaction, and suicidal thoughts or actions. There are some risk factors that may lead to major depressive episodes. These include brain biochemistry and hormone imbalances in the brain, such as dopamine and serotonin. Genetics also plays a role in predicting the likelihood of depression. Depression is also more common in people with low self-esteem, who are prone to stress, or who have negative outlooks on life. Finally, depression can stem from experiences with the environment, such as interpersonal relationships, violence, and history of abuse. Major depression is quite common in the United States. In 2016, approximately 7% of Americans experienced a major depressive episode. Depression is more common in women, with almost twice as many cases of major depressive episodes as men. Statistics also show that depression is highest among 18 to 25-year-olds and among individuals of mixed race. These statistics come from a 2016 study by the Substance Abuse and Mental Health Services Administration. So postpartum depression presents itself in a bit differently than major depression. This type of depression occurs after childbirth, but not always immediately. Symptoms may come and go anytime, usually within the first 2 years of childbirth. Some common symptoms include depressed mood, mood swings, and an inability or lack of desire to care for one's child. Further symptoms may include restlessness, anger, trouble concentrating, anxiety, sleep disturbances, including insomnia or excessive sleep, physical pain, withdrawing from loved ones, and ideation of harming oneself or one's child. There are some risk factors associated with postpartum depression, including the significant hormone changes during childbirth in oxytocin, a history of major depression or bipolar disorder, a family history of depression, because depression, as we discussed earlier, can have genetic links, and a history of alcohol or drug abuse. Other risk factors may be a medical complication within the pregnancy, a high stress event surrounding the pregnancy, such as a loss in the family, loss of a job, a lack of social and emotional support from loved ones, or a feeling of overwhelming pressure towards motherhood, which can have many societal implications as well. Postpartum depression is more common than it may seem. A 2012 study across 27 states by Ko, Rockhill, Tong, Morrow, and Farr of the Centers for Disease Control and Prevention revealed that 1 in 9 women experience postpartum depression. The study showed the highest percentage of symptoms among mothers under the age of 25 and among mothers of Native American and or Asian Pacific Islander descent. Considering the severity of these two conditions, there have been a number of screening methods developed for professionals to use for diagnosis. The guidelines focus on two methods. These two methods are the Patient Health Questionnaire and the Edinburgh Postnatal Depression Scale, the latter being only for postpartum depression. The DSM, which stands for Diagnostic and Statistical Manual of Mental Disorders, is also used for diagnosis, but it is not studied in this analysis. These screening methods ask patients to report and answer questions about symptoms that they are experiencing. They focus on the occurrence of the symptom and the severity of the symptom and work through a graded scale for the answers provided. Answers are given scores, and at the end of the questionnaire, the patient's score is totaled. Their total score is used to determine their stage of depression. In the case of most recently published patient health questionnaire, the depression was scaled from minimum to severe. Whatever method of screening is chosen, the experience should be, quote, defined as a structured or semi-structured diagnostic interview with a trained interviewer, or a non-brief, meaning greater than 5 minutes, unstructured interview with a mental health clinician. And that is quoted from O'Connor, Rossum, Henninger, Groom, and Berta of 2016. From the patient's diagnosis of depression, they have a number of treatment options. Treatment should cater to the best fit of the patient. Some patient options include cognitive behavioral therapy and interpersonal psychotherapy. Cognitive behavioral therapy, also known as CBT, is considered an identification and improvement of incorrect beliefs, and interpersonal psychotherapy is considered the development of cope strategies for interpersonal issues, according to Letourneau et al. 2014. Other methods of intervention are peer support strategies such as telephone hotlines, online forums, and peer support groups. Medications such as antidepressants and anxiolytics, which are used for anxiety, may be considered in addition to the previously listed methods. Now that there has been a proper introduction on the clinical problem of depression, we will move on to the clinical practice guideline description.
Hello, my name is Alyssa Capili, and I will be going over the clinical practice guideline description. This is a 2016 update to the 2009 U.S. Preventative Services Task Force recommendation on screening for depression in adults over 18 years old. It evaluates the effectiveness and associated harms of screening for depression in adults. The guideline category is prevention and screening, and it applies to the clinical specialties of family practice, obstetrics and gynecology, preventative medicine, psychiatry, and psychology. It's intended for use by advanced practice nurses, physician assistants, physicians, as well as psychologists and non-physician behavioral health clinicians. This clinical guideline focuses on pregnant and postpartum women as well as the general adult population, including older adults. Some key questions that it addresses for pregnant and postpartum women are: do primary care depression screening programs in pregnant and postpartum women result in improved health outcomes? For example, decreased depressive symptomatology, decreased suicide deaths, attempts, or ideation, improved functioning, improved quality of life, or improved health status. Under the category of this first key question are the two sub-questions: does sending depression screening test results to providers with or without additional care management supports result in improved health outcomes? And does the effect of screening vary by population characteristics? Key question number 2 for pregnant and postpartum women is: what is the test performance of the most commonly used primary care depression screening instruments in pregnant and postpartum women? Do the test performance characteristics of the screening instruments vary by population characteristics? Key question number 3 is: what are the harms associated with the primary care depression screening programs in pregnant and postpartum women? Do the harms vary by population characteristics? Key question number 4. Does treatment, whether it be psychotherapy, antidepressants, or collaborative care, result in improved health outcomes as listed before in pregnant and postpartum women who screen positive for depression in primary care? And do the effects of these interventions vary by population characteristics? Key question number 5. What are the harms of treatments in pregnant and postpartum women who screen positive for depression in primary care? Do the harms vary by population characteristics? What is the prevalence of other selected serious harms of treatment with antidepressants in the general population of pregnant and postpartum women? Key questions for the general adult population, including older adults, start with: do primary care depression screening programs in the general adult population, including older adults, result in improved health outcomes as listed before? Does sending depression screening tests result in improved health outcomes? And do these effects vary by population characteristics? Key question number 2 is: what are harms associated with the primary care depression screening programs in the general adult population, including older adults, and do these harms vary by population characteristics? This guideline was developed by a USPSTF independent expert panel. The USPSTF is a federally funded panel of independent experts, but does not necessarily reflect the policy of the Department of Health and Human Services. It is an independent voluntary body, and the U.S. Congress mandates that the Agency for Healthcare and Research Quality support the operations of the USPSTF, and the AHRQ provided funding for the development and updating of this guideline. This guideline was released on January 26, 2016 as an update to the prior 2009 USPSTF recommendation.
This is Ellen Colwell. I'm going to discuss the methods used to develop the clinical practice guideline for depression screening in adults. This guideline has been developed for prevention and screening of depression in adults ages 18 and older. It is intended for use by clinicians, and the goal of the guideline is to update the 2009 United States Preventive Task Force recommendation. In developing the guideline, 5 key questions about pregnant and postpartum women were considered, such as whether there are any harms associated with screening for depression, or whether current screening programs result in improved outcomes. In addition, there were 2 key questions for adults in general, which also addressed current outcomes and harms for screening and prevention. This guideline was developed by using primary and secondary source searches, as well as searches of electronic databases. For general information on depression, investigators searched Medline, PubMed, and other scholarly journal databases for existing information. Meta-analysis, review of published meta-analyses, and systematic review with evidence tables, along with expert consensus, formulated the recommendations. The National Guideline Clearinghouse used an evidence synthesis prepared by Kaiser Permanente Research Affiliates Evidence-Based Practice Center to help formulate this guideline. For information on postpartum and pregnant women, investigators reviewed abstracts and full-text articles and also reviewed existing systematic reviews in order to synthesize their findings. Investigators defined postpartum women as those whose babies were younger than 1 year at the time of study enrollment. They required that studies assessing benefits and harms were conducted in a primary care setting, such as in an obstetrics or gynecology practice or in the pediatrician's office. Reviews were chosen based on their relevance, recency, and quality of search and evaluation methods. Regarding the harms of antidepressants, investigators determined that the review used was extensive enough that it was used directly in the recommendations, and the individual studies were not investigated further.
good and fair quality studies published in English were included. These studies were randomized control trials and non-randomized control trials that examined the benefits and harms of screening or treatment for depression in pregnant and postpartum women. In addition, studies of diagnostic accuracy of the Patient Health Questionnaire, or PHQ, and or the Edinburgh Postnatal Depression Scale, or EPDS, were also included. Systematic reviews and large comparative observational studies that examined the harms of antidepressants in pregnant or postpartum women, as well as randomized control trials and non-randomized control trials examining the benefits and harms of screening in the general population, were also included in this guideline. Psychotherapy studies could take place in virtual or mental health clinic settings. As we discussed in our previous article appraisal, telephone support is one way that women seek and receive mental health support for postpartum depression, so it's not surprising that virtual support was included in these studies, as it can be as effective as in-person sessions. These studies were only included in the review if participants were selected completely at random, and not if they were referred to the study or if they were known to have depression. Investigators also excluded studies that involved alternative therapies for depression, since one of the qualifiers was that care would be delivered in a primary care setting, and these treatments were not likely to be given there. Regarding the harms of antidepressants, investigators utilized a foundational review that included information on harms of treatment on both the mother and the infant. In order to assess the strength of evidence, investigators independently assessed the studies using USPSTF criteria and also supplemented with Quality Assessment of Diagnostic Accuracy 2, the Newcastle-Ottawa Scale, and AMSTAR. Ratings of good, fair, and poor were given to each piece of evidence. Studies that were rated poor quality were excluded, and good quality studies had adequate randomization, allocation concealment, blinding of outcomes, reliable outcome measures, comparable baseline groups, low attrition, acceptable statistical methods, and adequate adherence to the intervention. Fair quality studies did not meet most of the good quality standards, but were also not poor quality. When synthesizing and analyzing the data, investigators created summary tables that listed all key questions and outcomes. They were able to compare treatment for depression, usually cognitive behavioral therapy or CBT, against usual care for control conditions. Because the number of studies was small, investigators ran a sensitivity analysis for small samples. They also ran for sensitivity against false negatives, which they did not find. In order to formulate the recommendations, USPSTF assigned a letter grade to each preventive service that signifies the recommendation about provision of the service. In formulating these recommendations, they needed to first determine the harms and benefits and whether or not the benefits outweigh the harms. A key question to consider was whether a preventive service would improve outcomes if implemented in the general population. Grades ranged from A to D and also included an I grade for insufficient. A and B grades meant that the service was recommended and has moderate or substantial benefits. A being substantial, B being moderate benefits. C grades are for selectively offered service for a small benefit, and D grades are recommended against because the harms outweigh the benefits. In formulating the grades, USPSTF also focused on the certainty of the intervention's benefit, then also rated them as high, moderate, and low. High certainty involved consistent results from well-designed and well-conducted studies. Moderate certainty involved sufficient evidence but lower confidence due to inconsistency across the studies or a limited number of studies. Finally, low certainty involved flaws in the design methods, gaps in evidence, and inconsistency in the findings, among other things. The guideline was peer-reviewed before recommendations were made and was open to public comment. The guideline was also compared with other groups in order to assure alignment.
Hello everyone, I'm Emilia Vasilchuk and I'll be talking about the Clinical Practice Guideline Recommendations. The U.S. Preventive Services Task Force, or the USPSTF, issued new guidelines for depression screening in 2016, which are revised from the guidelines they issued in 2009. The USPSTF gave a B recommendation for screening for depression in the general adult population, including pregnant and postpartum women, regardless of risk factors. This particular recommendation applies only to adults aged 18 years and older. The recommendation guidelines for depression screening in children and adolescents are issued in a separate USPSTF guideline. The B recommendation means, based on the chart provided in the guidelines, that the USPSTF recommends practitioners to offer and provide depression screening as they have found there to be a high certainty that the net benefit is moderate, or there is moderate certainty that the net benefit is moderate to substantial. This essentially means that they recommend practitioners to provide screening for depression for all adults, including the elderly adults, pregnant women, and women with postpartum, as they have found there to be substantial benefits of depression screening and benefits outweigh the harms. The USPSTF recommends depression screening even if the individual does not have risk factors. They concluded that the presence or absence of risk factors alone cannot distinguish patients with depression from those without depression. However, they did mention a number of risk factors that are associated with an increased risk of depression. According to the guidelines, women, young and middle-aged adults, and non-white persons have higher rates of depression, as well as those who are undereducated, previously married, unemployed, those with chronic illnesses such as cancer or cardiovascular disease, mental health disorders including substance abuse, or a family history of psychiatric disorders. Among older adults, risk factors for depression include disability, complicated grief, chronic sleep disturbances, loneliness, history of depression, and poor health status related to medical illness. They also mention risk factors for depression during pregnancy and postpartum. These include having poor self-esteem, child care stress, prenatal anxiety, life stress, decreased social support, being a single parent, having a history of depression, difficult infant temperament, previous postpartum depression, lower socioeconomic status, and unintended pregnancy. These risk factors should not be used to isolate those who should be screened for depression. The USPSTF recommends clinicians to provide screening for all adults ages 18 and older. The screening should be conducted using accurate tests to ensure an accurate diagnosis and followed up with effective treatment and follow-up appointments. For depression screening, the USPSTF recommends the commonly used screening tests, which include the Patient Health Questionnaire, Hospital Anxiety and Depression Scales, Geriatric Depression Scale, and the Edinburgh Postnatal Depression Scale in postpartum and pregnant women. Upon accurate diagnosis, effective treatment of depression in adults generally includes antidepressants alone or in combination with specific psychotherapy approaches such as cognitive behavioral therapy or brief psychosocial counseling. Psychotherapy could also be used alone. There are a number of benefits of early detection and intervention and treatment of depression. The USPSTF found that programs combining depression screening with adequate support systems, such as effective treatment and follow-ups, to improve clinical outcomes and reduce depression symptoms in adults, including pregnant and postpartum women. They have also found convincing evidence for there to be a decrease in clinical morbidity among adults and older adults with depression who were identified through screening in primary care settings and then treated with antidepressants, psychotherapy, or both. The USPSTF also found that treatment with cognitive behavioral therapy improves clinical outcomes in pregnant and postpartum women with depression. The USPSTF found there to be little to no harm of screening for depression in adults. They also found that there is little to no harm of treating pregnant women or women with postpartum depression with cognitive behavioral therapy. They found second-generation antidepressants, such as selective serotonin reuptake inhibitors or SSRIs, to be associated with some harm, such as an increase in suicidal behaviors in adults ages 18 to 29 years, and an increased risk of upper gastrointestinal bleeding in adults older than 70 years, with risks increasing with age. However, they concluded that the magnitude of these risks is, on average, small. The USPSTF found evidence of potential serious fetal harms from pharmacologic treatment of depression in pregnant women. Although the likelihood of these serious harms is low, they concluded that the overall magnitude of harm is small to moderate. Therefore, clinicians are encouraged to consider cognitive-based therapy or other evidence-based counseling interventions in place of pharmacologic approaches when managing depression in pregnant or breastfeeding women.
Hi, this is Yoonsung Choi. I'll be presenting conclusions. Adults aged 18 years and older should be screened for depression, including older adults and pregnant postpartum women, according to updated guidelines from the U.S. Preventive Services Task Force, for short, the USPSTF. The USPSTF has determined that there is significant evidence that screening all adults for depression in primary care settings improves accurate diagnosis and treatment. Commonly used screening tools include patient health questionnaire, hospital anxiety and depression scale, geriatric depression scale, Edinburgh postnatal depression scale. If a patient screens positively, he or she is advised to undergo additional assessment to examine depression severity, comorbid psychological conditions, alternative diagnosis, and medical conditions. For patients diagnosed with depression, treatments include antidepressant or a variety of types of psychotherapy, including cognitive behavioral therapy and brief psychosocial counseling. Because antidepressant can potentially harm fetuses, the USPSTF recommends psychotherapy rather than pharmacotherapy for pregnant and postpartum women with depression. To maximize the benefits of these screenings, the USPSTF recommends that primary care facilities have adequate system in place, meaning that facilities should have the necessary systems and clinical staff to ensure that all adults are screened for depression. For positive screening, facilities should be equipped to either properly diagnose and treat the patient or refer him or her to a setting that can do so. These essential functions can be provided through a wide range of different arrangements of clinician types and settings. In the available evidence, the lowest effective level of support consists of a designated nurse who advised the resident physicians of positive screening result and provided a protocol that facilitated referral to evidence-based behavioral therapy. At the highest level, support include screening staff and clinician training, 1 or 2 day workshop, clinician manuals, monthly training lectures, academic detailing, materials for clinicians, staff, and patient, an initial visit with a nurse specialist for assessment, education, and discussion of patient preferences and goals, a visit with the trained nurse specialist for follow-up assessment and ongoing support for medical adherence, a visit with the trained therapist for cognitive behavior therapy, and a reduced copayment for patient referred for psychotherapy. Multidisciplinary team-based primary care that includes self-management support and care coordination has been shown to be effective in management of depression. Evidence is lacking on optimal screening intervals, but a reasonable approach might include screening all previously unscreened adults and using clinical judgment to determine if more frequent screening is needed in high-risk patients.
Thank you for listening to our presentation. We hope this provided some clarification on depression screening in adults in the United States. Here are our references listed in the bottom right corner of the presentation.